This is Dr. Jamie Koufman, and this is Dr. Koufman's Acid Reflux Hour. Today's topic is how to cure acid reflux the Koufman way. And I will tell you that I'm going to present a lot of material that's never been presented before. I'm going to present some material that probably should have been published but hasn't been published. And I'm going to give you a completely different idea about acid reflux. And many of the questions you ask me will be answered by this presentation. Before I talk about how to cure reflux, I'd like to talk about terms. The term GERD, or gastroesophageal reflux disease, is a very old term, and it means literally reflux from the stomach into the esophagus. It has been used as a wastebasket term for all reflux. When any of my papers on LPR, laryngopharyngeal reflux, hit Google, they were always put in GERD. So I'd like to suggest to you a couple of things. First of all, the term laryngopharyngeal reflux was created because my patients with pH documented laryngopharyngeal reflux or reflux in the throat did not have heartburn, did not have indigestion, and did not have esophageal disease, normal esophageal exams. So I needed a term that was different for ENT patients who had everything, a hoarseness, a sensation of a lump in the throat, too much mucus, cough, you name it. There are now too many symptoms to mention in a string. But it's not a very good term, GERD, because it's now confusing. I came up with a new term about 10 years ago for LPR, because LPR is hard to pronounce. It's not clear what it is. So the new term is respiratory reflux. And it is more obvious and intuitive. So anytime you have reflux here, it's respiratory. And that includes the lungs. So it's respiratory reflux is the new term. And I would recommend that the GIs would be happy with esophageal reflux. And some people have both reflux esophagitis and also airway reflux. So the term GERD ought to go away eventually, and I do think that respiratory reflux is a pinnacle term. I'm going to talk to you how to cure reflux. I am asked what is different when I do a consultation. I've been doing 30-minute consultations, virtual consultations with people all over the world now for about 2 years. And they submit to me a complicated and fairly lengthy input form. And then when I see certain things, I ask to probe them before we get into the whole history. And those people are very, very happy, and most of them get well. At one point, my staff contacted a large number, and many as they could, and 75%, about 3 out of 4, were very well. And those are people who had been to Harvard and Hopkins and Cleveland Clinic and so on. So understand that respiratory reflux is sort of a great hole in the healthcare system. And the main reason, I'm not going to belong this, is that the air digestive system is one system. It's never divided up into parts. So you've got the respiratory people, and then you got the GI people, and then you got the otolaryngologists, the ENT people. Actually, the otolaryngologists should know the most about it, because this is where the rubber meets the road. This is where the respiratory and digestive systems connect. So having 3 different specialists to take care of one system doesn't make any sense. I always tell people that I'm part otolaryngologist, but the part that they don't know about, part pulmonologist, but the part they don't know about or know about much, and part gastroenterologist. And so what happens is we create a new field called integrated aerodigestive medicine, and that's going to be the future. Meanwhile, how to cure acid reflux is not easy. I've come to a conclusion that I didn't really know until a few years ago, that reflux is a chronic disease. So lower esophageal sphincter gets stiff and swollen for whatever reason from reflux, and doesn't work very well. The inflammation makes it not such a good valve. So the more you reflux, the more inflamed and stiff it becomes. So now you're having a recrudescence of cough after a respiratory infection, and it goes on for weeks, months, and then maybe later on you take a trip to Italy and you come back and you're coughing again for weeks or months. And so I believe that the reflux is not cured, that there's a baseline low level unless you cure it. And cure it means you have to stop at 100%. So the GIs use proton pump inhibitors, and proton pump inhibitors are acid blockers. 0% of people get well on PPIs. Let me say that again. 0% of people get well on PPIs. The symptom of heartburn or whatever may go away, but the disease marches on, and long-term use of PPIs is associated with esophageal cancer. So, respiratory reflux, I'm going to talk about now, because it's bigger, and everything that goes with GERD, heartburn, indigestion, the same admonitions and suggestions are going to come. Now, I'm going to tell you that doing a detox isn't easy. And the reason why we do a 4-week detox is we know it takes 3 weeks to wash out pepsin. Wash out may not be the right word. To get rid of your pepsin. Anti-reflux treatment is about getting rid of pepsin. Pepsin is sitting in your throat, and you can see it if you look on my Alkaline water blog with a man that has made out of water. It's a beautiful biopsy. You can see pepsin is everywhere. That's the job, getting rid of pepsin. Because pepsin can be reactivated if it's pH 6, and then acid comes along, say you have a Coca-Cola. So that's important. So let's just start. I'm afraid I'm going to get lose time. I want you to go to bed. These are 9 items, and here comes number 1. This is how you cure reflux. It's a 4-week detox. If you go to a wedding in the middle and have a chicken Kiev and 2 glasses of champagne, starting over, detox means no cheating, just like if you're in a drug detox program. You can't smoke a joint on Saturday night because it's party night. So this is 4 weeks and it's straight. And it's like a lot of other things. If you bang your thumb with a hammer a month later, it's fine, unless you're banging it every night or 3 times a week. So I want you to go to bed with an empty, an empty and quiet stomach. And empty means no food. And quiet means no activity, so no acid and pepsin and all the jazz. So I recommend an intermittent fast. Most intermittent fasts, you don't eat the first half of the day, and you can eat the second half of the day. Bad. I recommend an intermittent fast where you eat in the morning. Let's just say you get up at 7 and you go to bed at 11. Then you close the kitchen at 4. 7 hours, and don't change it day to day for a month. You close the kitchen at 4. You're going to disrupt your social life, but beside that, you're probably going to get hungry. Your stomach's going to growl. We found that both chamomile tea and ginger tea will take care of that. But you cannot have anything that has calories. So no sugar, no honey, because they can turn on insulin, turn on glucagon. So the stomach can be turned back on. But you can have artificial sweetener. So you're closing the kitchen, and no snacks. I mean, it's a fast. So 7 hours before. It's the hardest part of this, really. Before you go to bed, and you can take tea if you'd like. Those 2 are the ones that are recommended, and they don't seem to cause reflux. Secondly, I'd like you to employ gravity. All the wedges that are sold for reflux are useless, in my opinion, if you're trying to beat reflux. So I recommend 45 degrees. How do you do that? If you have a recliner, pillow it up. Put a blanket stuffed in that crack, put 1 for your butt, 2 for lumbar support, whatever you need, and so you can get the 45 degrees. That's gravity. If you have a bed that goes up at 45 degrees, know that you will have back problems unless you take some, precautions. So you need a pillow under your butt, you need a pillow for lumbar support, and you need a big one under your knees, and of course careful adjustment of your head. And it can be done sleeping on side too, but then you've got pillows everywhere, and you've built up in the middle. But in any case, if you ask me, closing the kitchen 7 hours before for a month and sleeping on an incline is really important. I had a patient, 29-year-old woman with a shortness of breath for, I don't know, 2-3 years young. And I couldn't get up the stairs to my office in New York, 32 stairs coming a subway. She'd be huffing and puffing, and this is not obviously common. The report was, I slept in a chair for 5 nights and my shortness of breath went away. So I'm telling you that the intermittent fast and gravity are very, very important. Next, by the way, everything I'm going to recommend to you doesn't require a doctor. Okay, you're the doctor if you have respiratory reflux. And that's because none of the doctors you're going to see know anything about respiratory reflux. Low acid, low fat diet. It's in my books, Dropping Acid and then Dr. Koufman's Acid Reflux Diet, page 46, 48. And it's also on the blog, jamiekoufman.com. Just type in a reflux detox diet and up it'll pop. You don't need to buy my books. I'm giving as much as I can to the public in a way that hopefully will reach as many people as possible. So the low acid, low fat diet, is pretty strict. Only fruits, melons, and bananas. No meat-ish. You can have poultry or fish for your meat and protein. Things like tofu and so on are okay. And nothing acidic. So no fruit other than the two that I mentioned. And for example, you can have egg whites but not eggs. So this is a low fat, low acid diet, and what you're aiming for is to consume nothing below pH 5. At pH 5, there's damage in the airway. In the esophagus is pH 4. We studied it. So you're on this low acid, low fat diet. Why low fat? Fat makes the lower esophageal sphincter relax, and so it's one of those key factors. So now we have you intermittent fast, closing at 4 o'clock, 11 o'clock, at gravity, and a low-fat, low-acid diet. I recommend that you never use a proton pump inhibitor again. I'm going to talk about detox, talk about rebound in a moment. I recommend 20 milligrams in the morning. And by the way, famotidine is generic Pepsid. On my site, I have a post called OTC, Over the Counter, and you can buy everything, including the famotidine, online with just a click. Famotidine is an acid reducer. It is not a proton pump inhibitor. In my opinion, it's the safest, most useful drug in the world. It's interesting because it's 7 times more powerful as an acid reducer than Zantac, which we used for a very long time. It has none of the drug interactions that Zantac has. It really has no side effects. So, people call me, whenever I take the famotidine, I get headaches. Or whenever I take the famotidine, I get rash on my hands. So anyway, to my knowledge, it's pretty much as safe as it gets, and you can acquire it without a doctor. So, one in the morning, 20 milligrams. 20 milligram, 30 minutes before your last feed, your last meal or dinner. And then most importantly, 40 milligrams, a double dose before bed. I also recommend alginates. Alginates are made out of seaweed. Gaviscon Advanced was the most popular reflux remedy in the world. It now has competition with Reflux Raft and Reflux Gourmet. It is still the least expensive one. If you're going to buy Gaviscon, it has to be Gaviscon Advanced. That's the name of it, and you want liquid. What it does is it rises to the top of the stomach, it forms a raft, and it helps with mechanical blockade. Most of you have supine nocturnal respiratory reflux, SNORR. And that's real. You have symptoms during the day, and you may have reflux during the day, but it's the night that really gets you. Why? As Americans, it's cultural for us to make our evening meal the big meal of the day, and I'm not going to go into causes of reflux, but reflux, silent reflux is the American way. I believe there's probably 100 million people who have it. And that includes the people who wrote this. This is the most progressive article I've ever seen. This is San Diego Consensus for Laryngopharyngeal Reflux Symptoms. For example, they didn't want to talk about globus and dysphagia, sensation of a lump of the throat, and difficulty swallowing, but we've studied it, and we know about the pressure differences here in the valve. And swallowing is really, really interesting because there's something called dysynchrony, out of sync. So people have trouble swallowing. Right there. The upper esophageal sphincter closes in the middle of a swallow. So we have famotidine. The alginates I recommend are after dinner and before bed. Just take a lick out of the bottle. It's hard to get it off the spoon. It's yours. And I don't think there's a problem with that. The least expensive one is still Gaviscon Advance, but the Gaviscon Advance is the name of the product. Alkaline water is very important, and I'm explaining to you why, particularly for people who have esophageal disease as well. Maybe someone has Barrett's or has had esophagitis. Here's the deal. We've looked at the activity of pepsin. In other words, it's most active, it does the most damage at pH 2, 3, 4. Unfortunately, gastroenterologists have got it completely wrong. I begged Don Castell to not, anything above pH 4 they call non-acid reflux. Wrong. Okay, there's acid effect all the way up to pH 6. But why alkaline water pH 9 and higher? Pepsin dies. Pepsin is about pepsin. You don't know what pepsin is, you better go to my site and look it up. So pepsin is basically broken down at pH 8. So alkaline water pH 9.5. In regard to pH water 9.5, the most popular one everywhere, I think it's a Coca-Cola product, is Essentia. If you notice, it has a phosphate in it, and people have told me it burns their throat, so I don't recommend it. I recommend that you get an alkaline water that doesn't have any phosphate in it. Just looking to tell you what's in it. Not only, and the article is very, very important, so I'm going to tell you about this article again. There's an alkaline water article in which the picture has a man made out of water. Toward the end of that article, even though you're not a pathologist, there's a biopsy. And it shows someone who has reflux, laryngitis, and hoarseness. So we took a little biopsy when they were having another procedure, and permission and all that, IRB. And you'll see a lot of round cells, a lot of inflammation, but that's not what's important. The next cut is stained for pepsin. We're the only people who've ever done that, my lab and Nikki Johnston's. So we stain for pepsin, and the pepsin is everywhere. It's on the surfaces, in the tissue, it's intercellular, it's extracellular. So getting rid of pepsin is what reflux treatment is for, and that's why we recommend a very strict 4 weeks. And that's assuming you don't have rebound hyperacidity from PP. I'll get that in a minute. So at the end of that article, same article on alkaline water, you'll see these little bottles. And these little bottles, I hear, are a thing on Broadway now. And here's why. Pepsin dies at pH 8. Well, when you drink alkaline water, your throat closes like your fist. And the larynx completely closes up. So let's say you're singing and you had a little reflux last night. Alkaline water doesn't have to be this one, but this one is small. It's on my website. I don't sell anything. I don't get any profit from anything. I'm not interested in having any conflicts of interest. But spraying the larynx is one of the only things you can do, the throat, to hasten removal of pepsin. So I recommend it, and it certainly is popular in New York. So you got alkaline water and alkaline water spray. And by the way, every one of these is scientifically determined. This is not, I made this up. I had a guy who had heartburn a long time ago, and he said, when I chew gum, it gets better. So we put pH probes in people all the time. We said, go eat lunch and come back. They come back and they're reflux, and we say, chew this gum. And the reflux goes away. It comes again, reflux gum. So you can abort post-SIBO or after meal, after eating reflux by chewing gum. I personally recommend cinnamon because you can't have any mint and the flavor doesn't last very long with juicy fruit and bubble gum. So I recommend cinnamon. That's what I use and what I like. And if you don't want to chew gum, you can have Ricola cough drops. Ricola cough drops. In Carnegie Hall, we're very interested in ambient noise. And all these people went out to dinner. They all had alcohol. They all have reflux. They all want to clear the throat and cough. So we put the Ricolas free for them to take in these things. Some people just, poured them in their pocketbooks, but most people took one or two, and the amount of ambient noise plummeted. So what happens is when you chew gum or suck on a hard candy, you make more saliva, more bicarbonate, you swallow a lot more, pushing the system forward. Now, so remember, we've studied everything. There's no makeup here, so understand science is science, and it's good science. My science has always been, I wonder what we're going to find. I don't have an axe to grind. I want to find out what it is. What's the truth? And there's only one more thing, and it's come to me relatively recently. I've written an article called Acid Reflux and Gut Health, and it's very, very interesting. I did some research to write it. In the end, gut health is going to turn out to be very, very important, and your gut health is going to be analyzed, and then you're going to be given whatever you need to replenish. And it's not just, the microbiome is not just bacteria sitting there. They're making some things available to be absorbed. They're preventing some things from being absorbed that shouldn't be absorbed. And so the whole deal is that people with reflux have a terrible microbiome. So I recommend a probiotic. I don't like to push any one thing, but the one I use is a Garden of Life for men and women, 90 billion, and it's on Amazon. So there it is. Intermittent fasting, bed at 45 degrees, good acid suppression, particularly at night, low acid diet, alginates, alkaline water spray, gum chewing, and a probiotic. Now, you do that for a month, and it's not easy. And by the way, a lot of people just say, I had a consultation with a woman who, we went through the whole thing, and she said, I don't care. I'm going to eat chocolate before I go to bed every night, regardless of all of what you've told me. And I said, you're going to have terrible reflux for the rest of your life. So understand that not everybody wants to be compliant, but doing it halfway only helps the symptom. If you have heartburn, antacids usually help. If you have cough, you have to really be much more aggressive in terms of treatment. But all of the symptoms, and by the way, the respiratory reflux includes sinus pressure, includes ear symptoms, it includes all the shortness of breath. I want to just talk about that for a moment. We're studying shortness of breath in people who have respiratory reflux, and about half of them have shortness of breath. Now, these are people who consult me, so they're sort of self-identified respiratory refluxes. But meanwhile, there are three types of shortness of breath. Type 1 is going upstairs, huffing and puffing. Type 2 is I can't get air in and out, like asthma. And the third is quite specific, and that's inability, discomfort, taking a full breath in. Nobody's ever reported that. It is actually the most common, and they have normal pulmonary function tests and normal chest x-rays. It's probably vaguely mediated. But the inability, discomfort to take a full breath in, maybe if they feel a full breath is going to be a cough, I don't know. But that particular symptom, in my opinion, is pathognomonic for respiratory reflux. Pathognomonic is a wonderful word. It's a medical word. And it means if you have this symptom, you have this problem. There's no wiggle room. Okay? If you wake up in the middle of the night coughing, gasping for air like a fish out of water, okay, you have respiratory reflux. All right? If you can taste reflux in the morning. Okay? So there are a lot of symptoms. So what I'm saying in the book that I'm writing right now is that what I did, which was using a pH probe with a high-quality pH meter, there's no reflux testing anymore. To go to your GI and have a Bravo, what's going on in the esophagus, and we don't know the pattern. Maybe you only reflux once a week on Saturday night because you do X, Y, or Z. Maybe you only reflux twice a month. We don't know. If it sits in a puddle all night in your throat or wherever your sinus is, and you have symptoms on your vocal cords get swollen, and the consequences of that have to do with pitch, and obviously for singers this is not a good thing. So they got the three types of shortness of breath. Now, if you were to ask me what are the biggest risk factors for reflux, eating too close to bed. I had a lovely woman, I think I've told this story before, from the Upper East Side. She had a surgery by the best surgeon I know, laparoscopic fundoplication, and she was refluxing so badly she couldn't go out of the house with her friends. She had everything, but the cough was the biggest one. So I said, well, what time do you eat dinner? She said, 8 o'clock. I said, what time do you go to bed? She said, 10 o'clock. I said, you're going to have reflux every night for the rest of your life. You cannot ever do that again. You just can't. And one of the things I want to point out here is some of these things that I've recommended to you are for the rest of your life. If you're eating at 8 o'clock and going to bed at 10, you're going to have reflux and all its consequences. As you get older, you start to get side effects and complications. Everything from esophageal cancer and lung problems to all of it. So I think that you know, you should probably, here's what I recommend. Never drink carbonated beverages or soda pop. Never go to fast food. Never have soft drinks, and never have alcohol. So eating too close to bed is the number one reflux trigger, and alcohol is number two. If you treat people and they lose their reflux, meaning they cured, about half of those people can drink alcohol in moderation and not have reflux again. But other people, you have a beer that night, you're refluxing that night. And by the way, if you get your reflux cured, and you got to go to it, you got to go to that thing, that dinner, and it's a little late. So you've been well. Take a famotidine, preemptive strike before you go. Take 2 before you go to bed with some alginate and sleep on an incline. So you're hoping that those precautions won't sling you back into the reflux abyss. So this is a very difficult program. There's no other way that I know of to get rid of it. Now, we're going to have other things that will help. We're working on an anti-pepsin product, but the real truth is the pills are going to be okay. But the spray, you can put an atomizer, and it gets everything, all of your airway, and it prevents pepsin binding. Okay, so that's going to help. But the reality is, we worked this out over a period of many, many years. You should know that over the course of my career, I believe I've seen about 100,000 people with respiratory reflux. And so when the gastroenterologists say, well, we don't know if globus is, only the cause of globus is a tumor, which is never, and reflux. And it goes away when the reflux goes away, period. End of story. We used to get repeat manometry at the end, and it wasn't worth it. So carbonated beverages, all of them have very, very low pH. FDA mandated acidification. You've never heard of anyone getting E. coli from Coca-Cola. So PPIs never. Now, if you're on a PPI, you just go to this whole program. Still, about a third of you are going to have rebound hyperacidity. It's going to be the worst heartburn and all that. So you double up on everything. Go get some antacids. Go get some Tums. Take a Gaviscon after every meal. Chew gum almost continuously. You suck on something, and you double up on these things. And so they're all preventative, and each one has a different mechanism of action. Rebound hyperacidity, a week or two. I've had in my practice 8 weeks, which is really unusual. Furthermore, PPI should be taken off the market. They have a tremendous amount of complications and side effects that you don't want to know about today. I have 4 articles on my blog on proton pump inhibitors. So I'm going to close with, don't eat too close to bedtime. Alcohol is a problem. If you want to really have a problem, have a nightcap. Go have a nice scotch or a brandy before you go to bed. Reflux guaranteed. Supine, nocturnal respiratory reflux, snore, S-N-O-R-R. That's what you got. Now, symptoms are how you make the diagnosis. You don't need to have a bunch of testing. First of all, the testing is useless. It's all esophageal testing. I see patients every week who the GI's done the test and the tests are all normal. And they have reflux coming out of their ears. They have every symptom. It's a constellation of symptoms. Postnasal drip, thick mucus is number one, 88% of you. Gets on your vocal cords, hard to move it off of there. Too much mucus, chronic throat clearing, that's number one. And then it goes, hoarseness, globus. I mean, all of these symptoms are very common, and most people have a constellation, meaning they have an average of 5.2 symptoms. So we looked at it, and in my practice, The average patient had 5.2 symptoms. We just looked at 100, but it was 5.2. So I've given you the cure to reflux. There is no other cure. Now, people ask me, there are a lot of questions here about procedures like links and all of them. We spend $1 trillion a year to get sick. That's all the bad food. And we spend $1 trillion a year on useless crap that makes people a lot of money. Venture capitalists, who knows? So none of those. I used to recommend Stretta. Okay, if you're not willing to make the changes that are important in your lifestyle and diet, none of these things will work. I just told you about a woman who had a fundoplication. Her little valve was stiff and swollen and inflamed. Now her big reconstructed valve is stiff and swollen and ineffective as a barrier. So understand that there's no way out. And when's the last time you had a doctor talk to you for 30 minutes about diet and lifestyle? It's it. Now, I would like this to go viral. I would like this to go to many people. It's not about me. It's about the ideas. So maybe some other doctor will see this and start playing the Koufman game. And it's a good one because you win. So get this video out and tell your friends and people who have reflux. Put it on your Facebook. Do whatever you do. But I'd like to see this one, which is really quite unique, go viral. So now I'd like to answer some questions. The questions are, some of them have been answered, but here's the first one from Candace. I've had every test and procedure under the sun, and everything came back normal until I did a barium swallow. Now, we started with barium swallow a long time ago. I like to see them upright standing and supine lying down. And if the reflux is going back and forth through the valve, you got reflux. If you can see it go up in the throat. If you have a cricopharyngeal bar, it means the upper esophageal sphincter is bad. I mean, what happens is you people, when you lie down, what's in your stomach is in your esophagus, in your throat, in your lung, wherever it goes. So, so barium swallow, I say to my consultees, look, if you're still having symptoms in 6 or 8 weeks, get your doctor to order a barium swallow, upright and supine, and that'll be a good test. And if you've already had one and you have reflux, good news, you can cure this. I didn't mention how you come off the detox diet, and I've forgotten to do that, so I shall. Take the thing you hate the most. You're on pillows and everything, but go down to 2 pillows. Change only one thing. Leave everything else the same for 3 or 4 days. See if your reflux comes back. You'll know. You want to add fruit. So on the post on acidity of all the fruits and vegetables. Try to stay above 5. Okay? And so what you do is you start adding things back. Now, for those of you who, businessmen and people on Wall Street who go to Keen's Steakhouse at 10 o'clock, have 2 cocktails, a gargantuan steak with a potato with all the fixings, béarnaise sauce on your asparagus, a chocolate dessert, and 2 glasses of wine, you have a 100% chance you are a world-class refluxer. Not my fault. That's what we found. The reflux pattern changed over the course of my lifetime. When we first started talking about laryngopharyngeal reflux, we had upright refluxes during the day, not so much at night. Around 2008, things started to change. And so now, supine nocturnal reflux is the deal. If someone wants to start a company, here's the way you make the diagnosis. You take a little tiny cup forceps, stick it through your nose, take a piece of tissue, and stain it for pepsin. Oh, turn pink, pepsin, respiratory reflux. All right, doing acid doesn't help. It's my test. Okay, I had patent for pepsin detection in the spit test. Problem is it doesn't work. It's at one point in time. But if you have pepsin in the tissue, you had pepsin in the tissue last week, and you have pepsin in the tissue next week. So I think the way to diagnose it will be a little tiny cup forceps, and someone will make some kind of a solution where essentially the immunohistochemistry is such that it turns a different color, or it doesn't have to go to a lab to be interpreted, which would be very, very cool. So Candace has something that concerns me I want to talk a little bit about. she said she'd been through them all, and my sore and burning throat just continues to worsen. Now, the vagus is the most important nerve in the body. I've written a 3-part article on the vagus, and I've written an article on neurogenic problems. Neurogenic means nerve caused. Burning throat is not usually a reflux symptom, although it would be made worse by reflux. So if you go to my article on neurogenic, and this is very few of you, if all you have is burning throat and it's killing you, then you have a description of what I actually do in terms of medication. I use amitriptyline and gabapentin for neurogenic. And 3 things I treat. I only treat 3. I treat a neurogenic cough, I treat burning throat, and I treat voice use pain. That's it. I had a woman who was a translator from Romania, did a consultation. She terrible pain with voice use. Didn't have reflux, actually. So giving her tools to try to make this better, I hope she did, because I never heard from her again. But imagine being a translator and having voice pain. Can I ask you if avocado is okay? It's interesting because when I talk to people and I give them the diet, I say, listen, you can have all the olive oil, all the avocados, and all the fish you want. Even though these are high fat, they're apparently the good fats, the alpha, omegas, and they don't cause reflux. I feel very fortunate. Understand, there's a lot of things I don't know. Why are they okay? But the answer is they are. Now, this is the kind of thing I know. How do I know? Because I've taken care of 100,000 patients, and the questions come up, can I eat avocados? And I said, I'm not sure, and I ate avocados, and everything was fine. So understand, I think that you can have all the olive oil, all the avocados, and all the fish you want. Dr. Koufman, I had manometry. Last year, that diagnosed me with esophageal dysmotility. There's a tricky question. Could this have been a result of radiation I had for breast cancer? Yeah. So radiation can cause problems in the esophagus and the respiratory system because you need saliva to neutralize acid. And so I think, and the dysmotility is usually not primary. By the way, all these doctors, they do manometry and a pH study or whatever. I guess they're using impedance, which is useless tests. A lot of people, maybe 15% of people who come to see me, we did manometry on everybody before putting the pH probes. About 15% have esophageal dysmotility that can get your attention. Note, I've had 2 patients with complete aperistalsis, no movement at all, dead tube, come back to complete normal after reflux treatment. So reflux is the cause of dysmotility in the vast majority of people, and dysmotility can cause reflux. And so you with the radiation, I'm not sure. I don't have enough facts. But it's a good question. Manometry, the next question about manometry and dysmotility, what advice do you have? Go on the detox program. Now, I've already answered this question. A relatively new surgery called reflux stop uses an implanted ball, and you can go on with Lynx and EndoCinch and Stretta. Okay, in my opinion, none of them are worth doing. Okay, nothing is going to take care of you long except a healthy diet and lifestyle. There's going to have to be at some point a push where you raise your kids. I don't want my kids to reflux. My kid is having trouble breathing at night. Time for the family to reset diet and lifestyle. You're gonna have to figure out if you're coming home from soccer practice at 8:30, you can't stop at McDonald's and get a big spread. Okay, so you're gonna have to figure out how to do these things in a reasonable way, and everyone's different. The hardest part about treating the reflux. So. The question is of burping. I think burping is reflux. After a lower esophageal sphincter opens and air comes up. Maybe it's aerosolized with acid and pepsin. A lot of people with reflux have it, and bloating of the stomach. My experience with that is when you treat the reflux, that gets better as well. Oh my gosh. Someone asked me, how is a consultation different than reading your book? The answer is, we talk eyeball to eyeball for a half hour, and whatever you need to do, and often it includes this detox program, and determining who has a neurogenic problem. It's a way to eyeball to eyeball, 30 minutes. Some of these questions. A lot of them, I don't want to be on PPI this week. Now here's one that's interesting. Dr. Koufman, a lot of smells, smoke, fragrances, detergents, cause me intense cough and difficulty breathing. Neurogenic. Okay? Reflux cough, cough after eating, cough lying down, cough bending over, cough overeating. Neurogenic. Perfume, diesel exhaust, going into air conditioning, talking on the phone. So it may be another neurogenic one. And something who wants to do a consult? You do. I know I'm way over, and I usually say Dr. Koufman's Reflux Hour and do a half hour, but today I think is really important. How do I get off Nexium? I've already told you. The only one I want to answer is two. Coffee. And we figured it out finally. The government, I can't remember who it is, says you can have 250 grams of caffeine a day. My experience is you can have 100 grams a day if you have reflux. So a large cup of coffee, yes, 90. I stopped drinking coffee, and I drink 2 cups of delicious English breakfast steak in the morning. That's 40 each. And if you like green tea is 30, and you can have 3. So try to limit that to 100 milligrams or less. And then the final one I want to address is I'm on a detox diet, and I'm losing 5 pounds a week. There's absolutely no reason to lose weight. Now, if you're picky and the only thing you'll eat, is melons and bread. So understand. I mean, here's an interesting one. I Googled, can you live on rice alone? You can't. Then I Googled, can you live on rice and fish alone? You can't. So it's about calories. Look at my article on rice. That breakfast has 600 and something calories and 60 grams of protein. It's a big bowl, so what I usually do is eat as much as I want, and don't get overeating, don't get too full. I put it in the microwave, because the cats will eat. I have 3 cats. I have some new Siberians that are breathtaking. I don't see. That's Tatiana and Katerina. So I'm done today. A lot of stuff has been covered today, and I really think that this is an important talk. And the reason why this is so important is people ask me, well, if I have this, is it going to help? If I have that, if I going to help? I went on your diet and it helped. But it's more than that. You got to stop the reflux. And if you do this for a month, and then by the way, the detox takes more than a month in the sense that you got to try one thing. And so it's really a 3-month workout to figure out with trial and error which are the most important reflux variables for you. So I'm signing off. Good luck, you all. I've given you an assignment that's not easy.